Thank you very much indeed. Good afternoon, everybody. I am indeed the Baroness Barker. I am officially a lady, and I'm delighted to be here as your chair, not least because I have been a member of the All Parliamentary Group on HIV/AIDS since God was a girl, really. I go back a very, very long way in all of this, and so it's great to be here. The first and most important announcement that I have to make is this. I have not yet started watching It's a Sin. So I have to tell you that if anybody does a spoiler, I will be forced to use my chair's prerogative and throw you out of the meeting. It's not that I don't want to watch it, I will watch it. It's just that, like for many of you, I'm going to have to summon up quite a lot of strength to do it. Why? Well, I wasn't somebody who was directly in the line of fire back in the day, but many of my friends were. And I was one of the allies who stood and watched as this whole horrible thing, unfold in our community. Now, like the rest of you, I've been watching social media and I have been reading the newspapers about this programme. And I think the thing that struck me the most was a comment that Russell T Davies made. And he said that he'd written it partly because there was so much that back in the day we didn't say to each other. We didn't ask each other stuff because in a way we didn't want to know the answers. There was nothing good that came of knowing the answers back then. Today, we are in a completely different place. And today, it is right that we should be asking everybody, have you been tested? How recently have you been tested? Have you talked to your friends about being tested? Because today, a test is a start of something good, not a confirmation of something bad. So today we do know that if we are going to get to our perfectly reachable point of ending HIV by 2030, the absolute and total key to that is testing for everybody, not just those of us who are privileged, not those of us who are savvy, but everybody. And so that's what we're going to be talking about today. How do we make getting tested the easiest thing to do for everybody so that we can have happy stories from now in? And what we're going to do is we're going to talk to some key people who are on the front line still, but also taking a longer view about how we get to 2030 and leading it all through. So I've got 4 wonderful speakers that I'm going to introduce, and then we'll come back to some questions at the end. But remind you, no spoilers or you're out. Okay, our first speaker is Ian Green. Ian, I remember many years ago taking a person called David Steele, who was my party leader. He was the first political leader to go to the Terrence Higgins Trust offices because we'd raised some money in what was seen at that time to be a very daring thing to do to support this organisation. None of us imagined all these years on that we would still be there, you'd still be there, and as necessary as ever. But please, Ian, talk to us about how things are today with THT and testing.
Well, thank you very much, Liz. And can I just pay tribute to you for your leadership of the as vice chair of your party parliamentary group and being such a consistent voice in Parliament around HIV and wider sexual health issues. So we've been asked to pose, a question's been posed to us today, is can England diagnose everyone living with HIV? Well, my answer to that is yes, we can, but that's going to require leadership, changing systems, and also additional funding to make that happen. Now, Terrence Higgins Trust was delighted to co-sponsor the Independent HIV Commission, along with our colleagues at the National AIDS Trust and the Elton John AIDS Foundation. And this is the first global independent commission that has been sponsored by charities that also got government support in advance to consider its recommendations. And we had an amazing group of commissioners, cross-party and parliamentarians, but also Damien Gabriel, the former Chief Executive of Lloyds of London, was an amazing chair of the Commission and certainly held us all to account in terms of that really important process. The Commission was supported by an expert advisory panel of clinicians, of representatives of the charitable sector, of academics, of people living with HIV. And that advisory group produced a wealth of documentation for the Commission, as well as the Commission went around the country to talk to local authorities, to commissioners, to community groups, and to people with HIV to make sure that they really understood the real issues on the ground and could really hone in on what the key issues were to end new HIV transmissions by 2030. And after a lot of thought, they came up with 20 key recommendations. And if you'd like to look at the Commission's report, do go on to hivcommission.org.uk or either any of the organisation's websites, and you will see a copy of the Commission's very detailed report and recommendations there. But one of the key recommendations was test, test, test. So we know that if we are going to end new HIV transmissions, everybody needs to know their HIV status. There are we've made lots of progress within HIV, but there are still very alarming rates of late diagnosis, particularly amongst women and Black African heterosexual men. And so whilst late diagnosis might be becoming less of a challenge for men who have sex with men, there are certain groups who are impacted by HIV where this is a really serious issue. And so the HIV Commission made a very clear recommendation that in order to make sure that we can get to a position where everybody knows their status, can get on effective treatment, and we know that once someone's on effective treatment and gets an undetectable viral load, it's impossible for them to transmit the virus to their sexual partners. That's one of the key ways that we're going to end new diagnoses. And rather than, as we do now, have a position of opt-in testing, the Commission's key recommendation that it should be opt-out testing. And so whenever anybody is in a healthcare setting and blood is drawn, it should be the starting point should be that someone is offered a HIV test. And we've seen in maternity services where that is routine, that virtually every pregnant woman has a HIV test, and we virtually eliminated mother-to-baby transmission of HIV since that happened. So that absolutely works. But we also need to normalise HIV testing in other settings as well. Our colleagues at the Elton John AIDS Foundation have an amazing project in South London, the Social Impact Bond, which is providing opt-out testing in a number of emergency departments in South London. And because of that, hundreds of people have been diagnosed with HIV who would not otherwise been diagnosed, and their health outcomes would have been much poorer because of that. Our colleagues at the National AIDS Trust have worked with a range of community organisations to focus on protocols around community testing, because we know that there are communities that testing in communities is far more effective than large-scale testing through self-testing or home sampling. So that's a really another important element. And in my own organisation, we have massively scaled up self-testing, where people test themselves at home and get the results at home. And we've been able to supply well over 50,000 self-testing kits from our charitable funds over the last 2 years. So testing is a key issue that we need to address. I'm delighted that the HIV Commission's recommendations have been so warmly endorsed by the government and also by the other political parties, because HIV should not be a party political issue. It's an issue, it's about health and social justice. And I think for me, it's making sure that we get that cross-party consensus. That is so important. So leadership will be needed. We need to resolve issues around who funds testing, because currently, because of the complicated health and social care system, particularly in England, there are different organisations who are currently responsible for funding, and we just need to make sure there are clear protocols in place so those structures aren't barriers. And we also need to make sure that stigma is tackled as well, because one of the key challenges for people not getting tested is the fear of stigma. And I'm not going to spoil anything for Liz, but that's obviously a key element that comes into It's a Sin, as if those of you have seen it. A personal reflection from me: I was diagnosed with HIV in 1996, so almost 25 years. And when I was diagnosed, I was told I might have between 8 and 10 years left to live. And for a 31-year-old, that was like having a rug pulled from under your feet. What motivates me is that no other 31-year-old will ever have to have that conversation with a consultant, even though we now know that somebody on effective treatment who's diagnosed today can have a normal life expectancy. It's still a shocking thing for anyone to hear. So that's what motivates me on a daily basis. Today is HIV testing week. This week is HIV testing week. It's been a remarkable week. In the first day last year, we managed to distribute 1,500 tests. This year, 8,000 tests. So we're delighted that that's happened, and the funding we received from Public Health England and the commitment from the government to make HIV testing week such a success is so important. And I know the Minister's going to say a bit about that later. So that's all I wanted to say in opening, Liz, but again, very happy to be here and look forward to helping to have a conversation with those here on the call a bit later on.
Thank you so much, Ian. Thank you. Our next speaker is the Reverend Jide Macaulay, the Reverend Jide Macaulay. Jide, as many of you will know, is an inspirational person. He straddles so many different communities, and he comes to every one of them bringing the most informed, interesting and insightful stories. And today I think he's going to tell us a bit about his own very, very inspirational story. So, Jide, without further ado, over to you.
Thank you so much, Liz. And I want to say thank you for the invitation as well. Of course, when we started to look at normalizing testing, I was asking myself, hasn't it been normalized yet? But, maybe like many people, obviously, when I first came out as gay, it was around about 94. And of course, finding the queer community was difficult, but nonetheless, I found it, and I found my own community. I think I started HIV prevention volunteering with GMFA charity. That's the gay men's charity in Southwest London. And then, of course, everything spiraled up. I was learning, and I was having a lot of knowledge around sexual health. But of course, in 2003, I went for one of my routine tests, to check my own HIV status, and it came back as a positive test. Like many people in that era, I thought, goodness me, this is a death sentence. How am I going to cope, and what's life going to be like? But I've been telling people that testing is very important. Testing is key to finding out what's going on for you. We're seeing the same thing right now with COVID. If you're having symptoms, the best thing is to test to eliminate, because the symptoms with COVID is flu-like. So it could be that you're having a flu symptoms, but go test to at least eliminate it. And that is some of the things that I'm trying to advocate today. But having said that, my journey took me further. And I've always said to people, this is not really about bragging, that the best achievement I've achieved is actually post my HIV diagnosis. I'm not saying that it took HIV for me to achieve other things, but, I started to concentrate more. And I think that, when Ian was talking about his own diagnosis 25 years ago, that was actually the time of the gloom and era. And honestly, Liz, it's difficult. I'm not going to spoil It's a Sin, because I have watched a few episodes myself. And honestly, you just prepare yourself with a lot of tissues and just be prepared for it. There's no doubt about that. But having said that, one of the things is that, as a religious leader, when I was already an ordained minister from my father's religious organization in Nigeria. So I was so concerned when I got diagnosed with HIV. I thought, oh my God, I'm gay and I'm HIV positive. This is a whole combination for hell. But, when I signed up with the Metropolitan Community Church, they took me on a journey of caring for myself and understanding. There were groups of people living with HIV in that community that also created peer support that I was able to join. But, the reality is that from my diagnosis specifically, in 2003, it took me up to 2009 before I could join a support group of newly diagnosed. You don't come along 6 years after diagnosis to a newly diagnosed. This is some of the things that are missing. So if we want to normalize testing, we have to be able to prepare spaces that people can have this conversation. We need to be able to knock aside stigma, knock aside the shame, the denial and discrimination. And that goes to every community. I'll tell you one thing, it's actually more worse in the Black community and in the religious communities, because we're not supposed to be having sex in the first place, let alone, sex with people of the same gender. So it's almost seen as deserving. And Liz, thank you so much for highlighting some of the things that I do. I have spoken out so much in the last few years, and any platform that allow me to speak, I will speak. I haven't been paid to promote this book, but
really?
Yeah, HIV.
I'll be the judge of that.
Who cares about HIV is an indictment on the church, a religious community that I'm also a part of. But I have to reassure people, we have to look at the balance. The church has also been doing their best to address HIV and HIV for a long time. But I think that the church can do more by ensuring that the priests and those who live in the church have the foreknowledge of HIV in our spaces. Thank you.
Thank you so much, Jide. I would just say that I know that the NAS project, and I think some others have had funding from the Elton John AIDS Foundation for their Testing Faith program, yeah, where they've actually gone along to a range of organisations, including mosques, places where you wouldn't think it would be at all likely that anybody would want to hear a message about HIV testing, but they've managed to have very good and productive conversations. That's a really excellent initiatives, and thank you for being an active part of it.
Thank you.
Somebody who's been around this as long as I have will know the most important part in what unfolded with the pandemic was that for perhaps the very first time, a group of patients were articulate, empowered, and began to talk with the medical profession about how they dealt with what was coming at them. And we perhaps forget quite how much it has been medical practitioners who have walked hand in hand with our organisation and community that has meant that we have made so much progress so far on HIV, and I think has actually led to a lot of the progress in general in vaccinations and pandemics that we know that we've seen speeding up things over the last 10 months or so. Never ever underestimate the amount of commitment and input from doctors, and so I'm delighted. Dr. Sean Perera, Associate Medical Director of Lloyds Pharmacy Doctor Online, we're here to talk about testing and how to do it. Sean.
Perfect, thank you, and such a pleasure to be talking tonight with such esteemed colleagues. So hello to everyone and thank you. So as mentioned, my two main roles are as Associate Medical Director for a digital health provider, so that is Lloyds Pharmacy Online Doctor, but I also work for the NHS, so I'm a GP and I'm also a specialty doctor in sexual health, so many hats. And today what I want to focus on is normalising testing, and I want us to consider what this actually looks like in practice. So with a bit of a focus more on primary care, but also bringing in some digital aspects, seeing as this is kind of one of our main routes to testing as it currently stands with lockdown. Now, when we talk about the undiagnosed, I think what we have tended to do in the past and what we tend to kind of fall to is focusing on population. So we look at the group, who are they? And then we divide them, and then we look into subpopulations and we kind of give them labels like, you know, how old are they? What's their gender identity? What's their ethnicity? And from that, we often tend to make assumptions about these groups, which in turn tend to lead to targeted interventions. So my question to you is, will that approach alone find the undiagnosed? And perhaps the clue's in the title, but the answer is no. So let's look at the undiagnosed through a slightly different lens. I think you've got to understand the population, but also you've got to understand the individuals within that. So you've got people who understand their risk, who might test regularly, who might access sexual health services routinely. But you've also got people who rarely or never access any health services at all. Those who perhaps don't understand their risk, and maybe even healthcare professionals who don't have time to consider HIV, or maybe it actually doesn't enter their differential when they're seeing patients. And finally, people are individuals, so they change. And I think we often forget this. They don't follow the patterns that we expect them to based on the groups that we've slotted them into. And I think we're at a stage in the epidemic where our approach to testing needs to change, and it needs to capture all of these individuals. So where does digital fit in? Well, I think there's no denying that it increases accessibility. It's been a lifeline, especially with lockdown. And in a world where you can just have about anything delivered to your door, where over 90% of households have internet access, there's a rising demand, and the need for accessing testing remotely is evident. But we also know that digital isn't for everyone. So it's this concept of one size doesn't fit all. And we do need to do some more work around those populations that are digitally excluded. But I think if we focus too much on that, given the rising demand and how times are changing, if we don't embrace digital, you will actually exclude far more people. And it's important to remember that. And so at Lloyds, without kind of plugging too much, but if you look back at the original service, which was founded by Tom Van Every as Dr. Tom, he actually claimed to be one of the first people to offer an at-home HIV test. Might be slightly contentious, but it was in the BBC News, so I take it as the truth. Through to helping 30,000 people know their HIV status over the last 5 years with our private service, which has slowly been increasing. But more recently, you know, we've been a partner in Sexual Health London, which has delivered over 700,000 tests since its launch in 2018. So that kind of gives you an indication of, you know, how we're pushing boundaries and how times are changing. And that model has been replicated, so it is available nationally as part of the Public Health England National Framework for ESRH. And if we focus on primary care, so I practice in Brighton and Hove, and I'm sure you've seen the letter that our MPs and the leader of the council sent out to Matt Hancock on Tuesday. And it highlights that Brighton and Hove really is ready, and this is really exciting. So my inspirational colleague, Dr. Jordine, who's a HIV consultant down here, and also trustee of the Martin Fisher Foundation, she's really been the driving force behind much of this. And we've worked really tirelessly to prepare our city for opt-out testing for the last couple of years. In Brighton, what we've demonstrated over a 12-month period is that late diagnosis cost our acute trust locally over £330,000. And if you think about the lifetime costs to the wider health system, this obviously could run into millions. And more importantly, I think we should remember these are people, so they don't all fit the perceived risk groups. And as a simple example, if you look at our recent diagnoses, these have included, you know, heterosexual white men, middle-aged women, and also some of our patients who've had quite a tough time with new diagnoses that come to mind. So one who's actually sadly incapacitated due to a late diagnosis was a nursing home manager. Another was a highly qualified nurse. You know, these are real stories. These are real people whose lives have changed. And if you look back through their histories and their contact with health services, there were definitely missed opportunities, and these occurred in primary and secondary care. So the point here is, if opt-out testing was the norm, that morbidity associated with their late diagnosis would have been completely avoided, and, you know, we wouldn't be in the situation that we're in now. And if I look at the projects that we've run locally, I think the three main barriers that we've faced, which I think are applicable to other areas, they are, first of all, commissioning of the tests. And so that's what Ian's kind of spoken about a little bit earlier, but there seems to be this perception that HIV testing is the local authority's business, and it's not. It's actually every commissioner's business. The second issue that we faced is laboratory capacity for testing. So our local lab has such limited capacity. Who's actually going to be doing these tests when they're done in the lab? And locally, we've had no choice but to actually outsource as part of wider implementation. And the third thing is GP workload. So, it's great to say, let's make it routine, let's put it out in general practice, but general practice is overwhelmed. We've got rising patient volumes, we've got increased complexity of patient conditions, we've got growing numbers of colleagues leaving the specialty, we've got competing demands, not to mention the horrendous 10-minute appointments that we have to stick to. Where does HIV testing fit into all of this? And I think many would say that the problem actually lies with general practice, and you kind of need to sort yourself out as a specialty. But I would actually say, come to work with me for the day, and you might think quite differently. And secondly, I think it's a lot bigger than this. I actually think it's more about a system change. So we need to look at things completely differently. And I think it's evident, HIV testing needs to be opt-out, but it requires a system change that doesn't impact clinician workload. And that's really imperative, as is a clear funding stream. And if you don't do this, it will fail. And also it will definitely not be sustainable. And such system level changes require changes to commissioning arrangements and funding with actual joint working between public health, CCGs and GPs themselves at the front line. And you need to get CCGs on board. They should be considering it as things of like part of their admission avoidance program. The time is now. What are we actually waiting for? You could make HIV testing part of the QOF. There's nothing to stop us doing that now. It will catch GPs' attention and put it on their radar. And finally, I think there's an engagement piece, not just at a national level through campaigns, but also in terms of educating our healthcare workforce. Make HIV e-learning mandatory for all NHS staff. Why not? All of this will raise awareness. It will reduce the stigma that Jide was talking about, and testing will increase. And finally, of course, remember, in the background to all of this, the future is digital, so always consider it. Thank you.
Thank you very much indeed, Sean. A seminal moment in the fight against AIDS came in 1996 with the development of protease inhibitors and the first effective therapies that changed this from being a terminal illness into one that could be managed. I remember being in New York and standing outside a pharmacy with some HIV activists as they stood and discussed actually on the street corner what this was going to mean for them, for their healthcare providers, and interestingly we then got on to what it was going to mean for politicians, because politicians who fund health systems are the third part of the puzzle. To be a politician in a day and a time like we are living in now, where we have scientific solutions to conditions, leads to another set of interesting questions, like how do we make sure that things like equity of access, how do we make sure that there are, where we have to prioritize resources, how do we go about doing that? So it's an interesting time in which to be a health minister, but not just a health minister who comes from a campaigning background of having been somebody who knows exactly what it's like to be a patient, and to be engaging in dialogue with all the different people who go up making that whole health system. So I'm delighted to ask Jo Churchill to talk on behalf of the government. Jo.
Thank you. Yes, that was my route to Parliament. It was as a campaigner, and it was a different diagnosis, but cancer, being given a diagnosis of cancer at 31 is not great news either. So, and then getting one at 45 and then at 47 you get really ticked off. So I thought, well, what can I do with all this latent energy? And my kids had grown up and were of an age I felt they should be, you know, burning their own tea. So I started on my journey to Parliament. But that then led me about 18 months ago to join the health department. And it's been a fascinating time and quite an exhausting time. So I too haven't done all of It's a Sin. Richard shamed me into watching one very, very early hours of Tuesday morning after I'd spoken to him, but I don't want any spoilers either, because I think I will end up binging it at some point. I'd firstly like to say how delighted I am to be talking to you this week of all weeks, and to thank Terrence Higgins Trust and all the charities who work in this area, and particularly the Commission, so ably led by Inga and David, who will ensure we keep thinking how we do it better. As the report said, the HIV sector is remarkable in its optimism and its pragmatism. And I know this attitude and the continued collaboration between the department, between stakeholders, and actually having some of those honest conversations that Sean just alluded to. Because whilst he mentioned digital, for me, one of the really big challenges is data and interoperability, and making sure that the right data is held in the right places to make sure that actually the care is the right care for patient outcomes. So that for me would be another one I would add in there. But I think that continued collaboration will get us to our shared goal, and that goal has got to be to end HIV transmission by 2030. There isn't really a choice. Zero transmission is an ambitious target, but I just would like to reaffirm this government's commitment to it. But I believe it is something that is shared. The Prime Minister has backed the target to end new cases. The Chancellor of the Exchequer endorsed the Commission report in the House. The Chancellor of the Duchy of Lancaster promised annual reporting, which I think is a good step forward, and interim targets to support the ambition of broader testing. And then just this week, my boss, our own Matt Hancock, who's also my parliamentary neighbour, whose endorsement is well known, he reiterated on Tuesday in Parliament his commitment to making sure we get to that 2030 target, and the need to identify the new targets that will make sure that we keep on track and we get us there. Part of the reason that I think we can be confident about doing it is by working together, awareness raising that it's a sin, but actually thinking back, you know, Doctor Who, there's been a lot of programs that have begun to raise awareness, and we have now got to a place where people are talking, and that really is the first step in educating. But I believe that over the last year dealing with the pandemic, it's shown us that everything is scientifically possible, and there are new ways of doing things. A vaccine in a year, mass testing, advances in treatment. This time last year, this last week, I went to Arrow Park to meet people flying back from Wuhan, and nobody thought we could do some of these things in the year, and we've shown they're possible. So on testing, currently home testing is a preferred approach during the pandemic, but I think at any time it offers a safe, confidential and simple option. It helps address the issue of stigma because it puts you in control. It allows you, if you're worried, to get a test. It allows you then to access help in the way that suits you. I know from friends that THT was often the only port of call some years ago when they needed that advice. Hopefully, with the increase in testing and allowing people choices moving forward, it becomes part of an individual's self-care routine, and it's just as normal as anything else. Now, we know we've got to reach more of the 77% to get to zero and then to keep there. And we're not always good in this country, it strikes me, of talking about our sexual health because we get embarrassed and all the rest of it. Even offering my daughters the chance to have a party when they became women, they pushed back and went, "Oh God, you're so embarrassing, Mum." But actually, it should be something we talk about. Sex is a very natural thing when you share it, and actually making sure that you can be with somebody you love safely has surely got to be the aim that we all share. So who's going to hold our feet to the fire in Parliament? I can assure you that campaigns by colleagues of mine keep it front and centre. Caroline Noakes pushing on the opt-out being an essential part of the change. Steve Bryan and Elliot Colburn on optimal PrEP delivery all help find solutions, not to mention Peter Kyle, who Sean mentioned wrote to Matt earlier this week, but he never lets me get off the hook on keeping our commitment to roll out PrEP and so on time. The ambition to 2030 means hard work, and we know for the last 3 years we've met the UN 90-90-90 objective, and we're only one of a handful of countries to do that. But we also know that the pandemic has been tough, and it's highlighted, as with so many aspects of healthcare, that there are large gaps. Take up in BAME communities, for example, is low, and this has to be a focus, particularly on the women, arguably, where we see a much higher prevalence. If we're going to reach the sort of 6,000 people that are living with the virus undiagnosed, we need to explore what more we can do. So later this year, we will be making sure that the sexual health strategy and HIV Action Plan that will be informed heavily by the Commission's report and the traffic light system and so on will be coming out. Now, in my lifetime, things are thankfully unrecognisable. The treatment pathway has been transformed. I listened to an inspirational HIV nurse earlier this week who spoke about that hopelessness. And I remember that as a young woman who left school in '82. And then the rays of hope in '96 with the start of effective treatments to now, where if testing positive, particularly early, treatment is kinder, less intrusive, and allows anyone to go on and have a life expectancy that's unaffected by the diagnosis. That is quite a remarkable journey. So making sure everybody has the same choice is really the important bit. So I'm going to finish on a bit of good news that I've been told I can tell you, which is that the government supported National HIV Testing Week this week, run by the Trust. It's been a brilliant success. There was a real fear that tests would run out before the week was out. The previous record set was 2,800 tests ordered in one single day. And we flipped THT flipped the numbers this week, and it was 8,200 rather than 2,800 were requested and sent to members of the public. So I'm really pleased to announce that via Public Health, the government have made another 10,000 tests available for those looking to know their status during this week. In conclusion, I would like to just commend Terrence Higgins Trust on the campaign and the It's a Sin cast who have taken this message, I'm sure, to the public as never before, but also the work that each and every one of you does to raise the awareness, because 2030 isn't far away. So we've got some work to do.
Thank you very much, Jo, and rest assured that the All Parliamentary Group will be holding your feet to the flame. We've been doing it for a long time. We're actually rather good at it, and we enjoy doing it. Okay, we have got about 15 minutes left, and we've got 4 panelists. So what I'm going to do is I'm going to synthesize down a number of questions that we had in advance and a number that we had now to two key questions, and I'm going to put them to all of you. Okay. The first question is this: with the advance of telemedicine and different types of remote working and so on, how can we in HIV use that to promote access, for example, in rural areas and so on, in ways that are consistent with work that is being done in other areas of sexual health, for example, in access to contraception, access to abortion and so on, in order to make sure that we get to those people who traditionally have missed out and have therefore presented later and with more complex cases. And the second question is, which communities do you think are furthest away from having normal testing as a normal part of their life? And we do know particularly about Black and minority ethnic communities. We know because of the stats with women in particular and Black and African men consistently presenting later. What is it that we can now do, given all the technology and all of the training and all of the possibilities for communication that we have at our disposal, to make sure that we get to those communities and make sure that they have full and equitable access to fast and timely treatment? Jide, you want to kick off with you?
Thank you so much. I was thinking that through as you were raising the question. I think that, HIV testing is not going to be entirely successful if we're to do everything remotely or online. There has to be people that can get in touch with people that they can talk to. I think that, there's still the issue of privacy. There are, within the Black community, HIV is a very sensitive subject, and people are still very anxious about their privacy around it. And that is why peer support group within the Black community, especially within the Black gay men community or people with HIV, is still very, very much sensitive. Now, of course, one of the things that I believe can be done is to improve on the privacy, improve on online information that are both culturally sensitive and very clear. And of course, online communities are also very important so that people know where to go to. And I think that I would also like to add then access to PrEP is also very important so that there's HIV prevention, even, alongside the testing, because when people come for PrEP, they're also testing for HIV, and that way we can actually get the numbers down. On the final notes that you make about some of the challenges, religious communities are definitely one of the most challenging ones. I strongly believe that a lot more education needs to go as part of the training for religious leaders, to be quite honest, so that they can have an open mind when it comes to HIV or any other long-term illnesses. Too often religious communities or religious leaders attach any kind of sickness to demonic spirit. HIV cancer is not demonic. It is, part of human existence that these things happen. And of course, the Black gay community are often ostracized already has been gay. So if you're diagnosed with HIV, it's a double whammy in a way, so that people can't cope with that. And that is why we've seen a lot more underground, people push themselves underground. I'm very optimistic that we can reach zero in 2030. I'm very optimistic, but we've got to do the right things for the right communities as well.
Thank you, Jide. I am no theologian, but I don't really think that there is any religious organization or body of teaching that says that endangering people's health is a righteous thing to do.
Absolutely.
Sean, would you like to think, using the new technologies and also getting to hard to reach communities?
Yeah, I'll focus on the digital a bit here, because I think the Commission report picked up many trends, didn't it? So it focused, like in sexual health services, it talked about heterosexual women being more likely than heterosexual men to decline a test, and then in terms of the ethnic groups that you've mentioned as well. I think, it comes down to this concept of one size not fitting all. You've just got to give people options. And you've got to unpack the subpopulations to kind of really get to the bottom of what their needs are. But that needs to be on a background of as many testing opportunities as possible, whether it be digital, whether it be when they're in the GP surgery, whether it be when they're having their smear test with a practice nurse, whatever that encounter is, whatever that contact is with a healthcare professional. Specifically focusing on digital, you have to be really careful, because we know that digital isn't the answer necessarily. It helps, and it will help many, but actually we know from work in other fields of digital health that actually populations are digitally excluded. So those who lack internet access, those with low levels of digital literacy. And the very determinants for these factors actually include things like older age, disability, learning difficulties, language barriers, being born abroad, culture, and these are the very people who are at greater risk of poorer health outcomes. So you have to be really careful that actually you're addressing these specific people's needs. So to answer your second question, I'd worry that we're furthest away from helping those groups in particular. I'm just scratching the surface, but you need to kind of unpack and really address those subpopulations in a lot greater detail.
Thank you. Ian?
So we did some polling in advance of HIV Testing Week, which showed that only 77% of the population have never been tested for HIV. And when you break that down further, that only 16% of heterosexuals have been tested, whilst almost 60% of gay men have been tested. So it's very clear there's an awful long way to go to make sure that everybody knows their status. And I think what I'm just following on from Sean's point, we almost need a smorgasbord of opportunities to enable people to get tested. So it's not just one size fits all. And that's why there's so much good innovation taking place in different parts of the country. I know that what's happening in Brighton very well because of our service there, and the really close joint partnership working that's taking place with the local authority, with community organisations, with the Martin Fisher Foundation and the Trust and GPs. And so that's the sort of approach we need to be looking to replicate in other parts of the country, as well as ease of access to testing, that people can get tested at home through digital platforms. So I think that's on that first point. Just in terms of communities that are where there needs to be sort of clarity around testing, and I think that we mentioned the BAME communities, and I think for me, access to testing for BAME communities is an issue of social justice and of human rights, and I think that we know that BAME communities are disproportionately affected by HIV. But also we know that BAME communities are not monoliths. And it's so very easy to stereotype, and I think interventions aimed at specific communities should always be led by those communities. I know Jide and I have had these conversations in the past, and that's why that's so important that particularly Black-led organisations are taking the lead in relation to speaking to the communities that they come from, and the funding needs to flow alongside that. So I think that we've got to be thinking about what are the barriers and making sure those barriers are unblocked. It's very easy for me as a middle-aged white gay cisgendered man to say what my view is, but actually that's not important. It's about making sure that we're listening very carefully to those communities about the best interventions for them, particularly around HIV testing.
Absolutely. I was privileged to sit and listen to some researchers who'd been talking, had been engaged in a project that was about a research project which was about PrEP in Uganda with young women. And hey ho, what works for affluent men gay men in London doesn't actually work for women in rural Uganda. Who knew? But we and that's the thing I think I would put to Joe in these two questions. I'd like you to think firstly about women, in particular about this month about women, and secondly, how do we make sure that people in government and Department of Health don't run away with digital as the answer to everything and suddenly start inadvertently knocking people out of the picture when they're the very people that we want to get to. Joe.
So thanks. I actually think it's about balance. Sean would be a good voice in giving the balance because he's a digital doctor. So actually saying there are still gaps, because he mentioned the digitally excluded. I was reading an interesting statistic, well, a sad statistic actually, about the number of homeless who were LGBTQ, it actually, and particularly young ones, so 24% it was. So how does anybody, you know, who's homeless, or how are we making sure tests are available through hostels, you know, in prison environments? There's lots and lots of areas. I mean, actually the traffic light system within the report, and actually a lot of the report gives solutions, but then it also has to be looked at in the environment of commissioning and all the other challenges that are out there. Most people reference their GP, but GPs are businesses in their own right rather than part of the NHS. So there's, as are pharmacies, and there is some untangling that you have to do within that. I actually think it's about allowing choice in this space so that people can choose the way they access the test. The big important thing is people know their status, because, for example, if a couple, it was an example that was given to me of a BAME couple. She was negative, he was positive, they found out, she took PrEP, everything was cool, right? Now, that saved, going back to Sean's earlier point, it saved the system further down the line. It also means, you know, there is less chance, because everybody is aware of their health status, of making sure they make the right choices, because also there is this education piece and how you then educate yourself and others about what the right choices are, because you don't know what you don't know. So I would say it's digital, but for me, don't only look at the test. Look at the information running up to the test, what motivates you to get the test, and then look at the information you provide afterwards. A lot of that can be done digitally. I've recently acquired a new godchild, and she has 2 dads, and I've known, they're very dear friends, and I said to him, we're rural here, and I said, what was the toughest thing? He said, our family doctor, who'd known me all my life. But I couldn't believe how understanding and kind he was. So I also think part of this is also understanding that broader, is the fear yours, or does the fear belong to somebody else? And that's part of a broader conversation as to how we do it. Challenging on certain communities, I would totally agree with Ian's point, not everyone's the same. And that even goes, I mean, this collective of BAME is very different. You know, it's that we're people. You can't just group people together like that. Now, if you like, what you can ask yourself is through COVID as well. And I think Jide started to go into that part of the conversation about people's own reasons for accessing healthcare, because we know there are real challenges with people accessing healthcare right across the BAME community. But I spoke to a GP early part of this week. He's actually taking a bus with vaccine out into the community, so people don't have to cross the threshold into the surgery. Maybe we need to think creatively. You know, is there a testing limo, you know, outside clubs? Is there, can we do things that are just a little less normal, because we tend to want to prescribe how we do health, and maybe population health, we need to think, particularly after this year, a little bit differently. So hopefully the action plan and the sexual health strategy is going to give us some of the answers. But I don't think it's as easy as sometimes these conversations make it sound.
Thank you very much, all of you. I hope to our audience you have been inspired. And if you have been inspired by this, I hope that you will go to the All Parliamentary Group's website, and there you will see details of the 2 inquiries that we're going to run, one after the other. One is simply about testing, but the second one running into that is specifically about testing and Black, African and South Asian communities. I really would like you to do that. On the chat, somebody said something about how fantastic would it be if Russell T Davies wrote a series 2 of It's a Said, which took us from the early 90s through to the present day, looking at how things have changed. Well, I hope
you didn't say the end bit. Does anybody know him?
Well, I was gonna say for somebody get in touch with his agent, but it did set me to one. Here's my parting gift to THT and everything. I can't write a series. I'm not Russell T Davies. But had I the wherewithal to do it now, I would come up with a campaign that said, "Getting tested for HIV, it's not a sin," and I would go with that. And I would put that through to all of the people that, particularly Jide's been talking about it today. Back in the day, things were grim.
Yeah.
Today, they are not. Things are hopeful.
Yeah.
That's the message that we have to get out to people. You're all part of that. Please do continue to work with all of our groups, and particularly with the APPG. Let's make sure, as Ian said, that no kid ever goes through anything like what we had to go through all those years ago, not even for one moment. Some of us are going to have to leave because we've got to run off and do other things. I believe that some of the rest of you can stay and chat, and I hope that you do. Because there is nothing worse than a Zoom meeting where you've been itching to talk to people and you can't do it. So you've got about 15 minutes. But from me, thank you, everybody. And please, everybody, would you thank our speakers? Thanks.